Do you know CPR? No, not that CPR, but this CPR. Clinical Prediction Rules. It refers to a scientifically developed, validated, and tested set of factors that have been shown to assist clinically, hopefully saving time and money and at the same time benefit the patient. So, how do you predict what the weather will be like over the next week? Listen to or watch the weather report? Base it on past weather patterns in your area? Look out the window or just go outside to look? Well, most of the time the weather report is accurate, but sometimes you need to use your real-life observation to compensate when they're not. Well, CPRs are similar in that science is used to predict something, but given the microclimates of your patients, it can be generally true, but not always with the patient in front of you, and requires that you have to be the direct observer part of the decision, even when clinical prediction rules are used. Clinical prediction rules are designed to assist the clinician in making decisions about one of the following: screening and diagnosis, prognosis, and interventions. Although designated as a rule, they really reflect an algorithmic approach to the patient with the hope that prediction of the intended purpose is much better than through clinician guessing. You may be surprised at how many CPRs have been developed. Their range certainly spans a host of concerns, many of them relevant to chiropractors. Well, let's look at some examples of each. Later, we'll pull out a couple of these to demonstrate how they were developed and how to judge whether the CPR is strong enough scientifically to incorporate into your practice. Here, for example, are a number of screening CPRs. You can see that many of them might be used in your practice with regard to determining the need for radiographs with neck, foot, ankle, or knee trauma. Perhaps practitioners with a sports focus will find these even more relevant given the decisions necessary on field. Here are some CPRs for diagnosis. Note that all of these conditions are seen in chiropractic practice, and even if the CPR is not used, you'll find the information in the studies that generate the CPR is valuable and worth considering in your practice. For prognosis, it's important to remember that patients, payers, and I'm sure you are interested in prediction of success. Some of the interventional CPRs shed some light on the types of patients that might respond to manipulation, and more importantly, support the use of manipulation in a number of scenarios. These are perhaps a little more prescriptive, giving suggestions about specific protocols to follow. As a side, many of these interventional CPRs were developed by physical therapists. In fact, a number were developed by a core group of therapists, usually in conjunction with MDs. The caution here may be that the manipulation used may not be a mirror image of the types of manipulation that DCs use, although some are. So when would you consider using a CPR? Well, when you encounter problems you don't see on a regular basis, especially when using diagnostic CPRs and interventional CPRs. When you wish to demonstrate the scientific basis for a treatment plan you've proposed, maybe in defense of your management plan to an insurance company, or for patient confidence. And when you want to find a more cost-effective approach. Many CPRs were developed with this as a primary motivation. There should be 3 progressive steps in the development of a scientifically sound clinical prediction rule. They are derivation. This is the study from which the CPR factors are derived. Validation, this is when it is tested in a different population of patients. And finally, impact analysis, where it's applied across multiple settings in the real world to see if it's met with acceptance and is practical. How would you decide which factors are worth paying attention to, the most reliable indicators? Well, it's best to start with a prospective cohort design. This is a study that follows patients or subjects forward in time. Patients go through a standardized exam with a reference standard test if it's diagnostic, or a specific treatment if it's interventional, or wait a specific period of time if it's prognostic. For interventional studies, a validated outcome measure with strong psychometric properties is selected. Well, what does that mean? Well, the outcome measure, such as a questionnaire on patient function, has been demonstrated to have discriminative value, one that possesses a difference score that identifies a clinically important change for the patient. Once the patients are dichotomized into successful versus unsuccessful, variables are compared in these 2 groups to determine univariate associations, meaning each element or variable is analyzed for its own individual value. Those with significant univariate associations are then combined into a multivariate analysis to determine the contribution of a group of predictors. Variables that become part of a group prediction of variables may not necessarily be the most significant individual predictor variable. Now, two things can happen. Either these variables are brought together into a clinical prediction rule and published as a derivation study, or in the same study there are two groups of subjects. One group acts as the derivation group, the other the validation group. In other words, that sample of subjects has the rule applied to them to see how well it performs. Scientifically, this is a weaker validation approach because it uses subjects from the same setting, which makes conclusions about its validity for extrapolation to other populations less sound. Ideally, validation occurs in a separate study with a different sample with different prevalence and spectrum of that disease. The last phase, which is rarely performed, is the impact analysis. It makes no difference how scientific your prediction rule is if it's met with strong resistance, is too complicated, too cumbersome, too expensive, or simply not feasible in environments outside of the derivation and validation settings. Judging the soundness of the advice given by a clinical prediction rule has been categorized as 4 levels. You can see that level 1 is highest, with at least one prospective validation study plus one impact study. There are very few of these. Next, we have level 2, where at least one large prospective multicenter application has been performed. Level 3 means that there is at least one validated prospective study, and level 4, which most CPRs are, includes a derivation study, but the rule has not been validated outside of the derivation study. We're going to take a look at several CPRs and start with screening and diagnostic clinical prediction rules, how they're developed, and review them to get a sense of how they are conducted and formatted for use. So let's briefly review the statistical measurement terms for diagnostic tests. Within the tests, we have sensitivity, specificity, positive and negative predictive values, and positive and negative likelihood ratios, meaning these statistics reflect the results only for the study population. Remember the acronym SNOUT, where a highly sensitive test when negative tends to rule out the condition, and, of course, the acronym SPIN, where a highly specific test when positive tends to rule in the disorder. Sensitivity and specificity are independent of the prevalence of the disorder, so we need statistics for that. Well, this is where the positive and negative predictive values come in handy. Next, we need to access likelihood ratios, which are derived from sensitivity and specificity. So independently, the likelihood ratios are a good benchmark of the value of the test's ability to rule in or rule out by matching that value to a standardized table of whether it increases or decreases the probability, and most importantly, by how much. Although likelihood ratios do not take into account the prevalence of the disorder in the study population, they can be used with an estimate of prevalence in your patient population to arrive at a post-test probability. So here's how this is all put together. By estimating the pre-test probability or prevalence and using a nomogram with a likelihood ratio, a post-test probability can be estimated for your patient. Here's an example of a nomogram. Note that by starting with the pre-test probability and drawing a line through the likelihood ratio, you end up on a point in the post-probability ladder. Let's look at our first CPR. This is a screening CPR. Its purpose was to screen patients with neck injury to determine whether x-rays are needed to identify fracture. Some of these may seem commonsensical, but given these were used in emergency rooms to decrease unnecessary time and expense, they must include the obvious. What they do is give the clinician an out for not taking films, whereas prior to the rules, all patients would have x-rays ordered for them. Here's a crucial point about screening CPRs. They're used to rule out, not rule in, meaning the sensitivity must be quite high, close to perfect given the seriousness, but they do not have to be that specific. Well, why? If you're screening with a highly sensitive test, you're going to capture some patients without fracture, but you're not hopefully going to miss any who do have fracture. The next sequence is to then find out which of these were true positives through rule-in with radiographs. They need to be highly specific because you don't want to manage someone as if they have a fracture if they don't. Well, this carries forward in our next two screening CPRs, one for foot and ankle fractures and one for knee fractures. These were developed by the same individuals, again in the emergency room setting in Canada, with the intent of avoiding unnecessary cost and time for the patient. All of these screening for fracture CPRs have been validated in prospective studies and multi-center studies. Next, let's move on to diagnostic CPRs, but before we discuss the CPR, I want to give you a quick and easy approach you can use that will often produce similar results. This is called the diagnostic odds ratio. What a diagnostic odds ratio does is to provide a hierarchy of tests for a given condition, in essence showing the most valuable to the least valuable by dividing the positive likelihood ratio by the negative likelihood ratio. Here's an example for lumbar radiculopathy. You'll notice that they are in order of highest diagnostic odds ratio to lowest, but you will also notice that it doesn't say what the value is, in other words, to rule in or rule out lumbar radiculopathy. This still needs to be gleaned from reviewing the likelihood ratios. Here are the diagnostic odds ratios for cervical radiculopathy. Look at these and you'll notice something interesting as we move on to the diagnostic clinical prediction rule for cervical radiculopathy. Well, here it is. You can see that the diagnostic clinical prediction rule matches closely with the diagnostic odds ratios. The message is that when a diagnostic CPR does not exist, you can make an attempt to approximate using diagnostic odds ratios. Finally, let's briefly consider regression. It's used to consider the role of several variables simultaneously in a multivariate analysis, and the weight that each variable contributes to predicting the outcome of interest. It has a lot of aliases, as you can see here, but we're more interested in its application. Here's an example of a screening CPR for the need for densitometry for women suspected of having osteoporosis. You can see that through logistic regression, they pulled out of a long list of potential indicators 6. Rheumatoid arthritis, history of previous fractures, older age, non-estrogen use, and low weight. By assigning each a numerical weight based on how much each contributed and summing the numeric weights, they arrived at the predictive model. Although this was for a screening CPR, this approach is also used for diagnostic and interventional CPRs. Here's an example of a prognostic CPR for the recurrence or persistence of sciatica. Again, through logistic regression, they were able to narrow down a large list to these 4 factors: driving more than 2 hours a day, carrying heavy loads at work, a high level of psychosomatic problems, and sciatic symptoms the year before. We will end by looking at 2 interventional CPRs that will be of interest to you. The first is whether lumbar mechanical traction will be effective for patients with nerve root compression. You can see the rule if peripheralization with repeated lumbar extension occurs and if the patient has a positive cross straight leg raise, then the patient is a good candidate for mechanical traction. Peripheralization is referring to pain that radiates down the leg as opposed to staying centralized to the low back. If these 2 factors are present, the rule is able to differentiate 84% of patients who recover using traction versus only 45% who recover without traction. As you might guess, there is some prescription here about how the traction is applied. The traction is applied with the patient prone on a table that allows extension and side bending. The table is adjusted to allow centralization of the pain with these 2 features. Static traction at 40 to 60% of body weight for a maximum of 12 minutes is applied. The patient remains prone for 2 minutes after traction, then performs 10 prone press-ups prior to standing up. Probably one of the most famous CPRs is the one by Flynn et al. For the success of lumbar manipulation for low back pain. Again, a caution here that the manipulation used is a twisting motion on a patient lying supine, both legs lying on the table straightened. The CPR involves the following: pain does not travel below the knee. Onset of pain is 16 days or less prior to treatment. Lumbar hypomobility is determined by the practitioner using a P to A force through each spinous process to determine restriction. And next, either hip has greater than 35 degrees of internal rotation. And using a questionnaire called the Fear Avoidance Belief Questionnaire and a subset of those questions for work, the patient has a score less than 19. The judgment of success was a 50% improvement in the baseline modified Oswestry Disability Questionnaire. Subsequent prospective validation studies have been performed that indicate that success may extend to 6 months. The success rate was 60% with less utilization of healthcare resources. A reanalysis of 2 studies indicated that only 2 prognostic factors were needed: no pain below the knee and duration less than 16 days. This CPR is still very controversial because of some of the statistical methods used. However, it may serve as a starting point for future attempts. Well, let's summarize. Most CPRs have only made it through the derivation stage and not the validation and impact analysis stages. And some of the interventional CPRs are based on studies that did not always compare the intervention to placebo or natural history. With that being said, many of the CPRs, especially the diagnostic CPRs, are a good starting point for what should be considered in looking at preventive, prognostic, or interventional approaches to your patients. Please take the time to read the specifics of the articles from which CPRs are derived. Also consider the text Clinical Prediction Rules by Glenn and Weisbach, a wonderful overview of existing clinical prediction rules.